It's a delight, it's a pleasure to be here with you today. They've let me out of my box to speak to you. I think this is our first sort of public engagement because everything has been locked away. And some of you I already know, and it's lovely to catch up with you again. I'd start by paying my respect to the traditional custodians of where we're meeting in Canberra. This was always a place of meeting. And also my respect to a group that I'm going to address within my talk today, those people who are suffering from PTSD and perhaps are not being catered for in a way that exemplifies everything that medicine can do for them. So I'm going to be talking about this business of converting swords to plowshares, this much maligned group of drugs, which has always been a source of evil to people who describe it, into perhaps even medicine itself. You might think that I'm the world's worst person to do that. I'm not a psychiatrist or a psychotherapist. I'm neither a neuroscientist nor a psychologist. I don't get any funding from it. I just get my wage, and then I give that to the missus, and she feeds the kids. I do have an NHMRC partnership grant. I'm an emergency consultant, and I do have a little bit of an interest in illicit drugs. We, as emergency consultants, tend to be Jack and Jills of all trades, so we can get our heads around quite a few things in a superficial way, and this is something that's been interesting to me, the repurposing of illicit drugs, probably for the best part of 2 decades. I do provide, by way of declaration, pro bono, non-partisan advice to a whole bunch of different politicians, some non-government organizations and other institutions. I'm also an Irishman, as the more astute of you would be able to tell, with a special interest in politics and policy. And so in this space today, this is exactly what we're going to be talking about. This is an interposition of this business of illicit drugs and politics and policy. So I'm going to chat, with your blessing, about psychedelic drugs today. What are they telling us about how the brain and the mind works? And what can they do for us when the brain or the mind doesn't work? This represents a brand new paradigm of treatment, something that you all may feel is a little bit airy-fairy and a bit silly, and I know I did when I first got into it, but there's substance there. There are hurdles as well. There are many of you within this audience, dare I say it, might have preconceived notions about illicit drugs, and you might as well leave now, because I'm going to make you sad. They're not all evil. Not all people who use drugs currently considered as illicit are evil or bad. There's a lot of people who use these illicit drugs for therapeutic gain. And this is the backbone of what is now becoming an extraordinary multi-billion-dollar endeavor overseas. The use of these sort of products is older probably than the existence of the written word. Certainly cannabis has been dated back to tombs from probably 8,000 BC. Many other drugs which are out and available, ayahuasca, have been used for hundreds and hundreds of years, not by young party-going individuals for the purposes of getting high, but for therapeutic intent. And they come by a whole bunch of different words: psychotropics, hallucinogenics. Hallucinogenics it's a term that's used in this slightly derogatory way, I suppose. Psychotomimetics, that's very old. Entactogens, entheogens, those drugs which bring you closer to God. I quite like the idea of the psychedelic. So this dates to back in a time where people were looking at this in considerable detail, where Aldous Huxley, the man behind the Doors of Perception, was writing to a psychiatrist, Humphrey Osmond, and came up with this word from the Greek, psyche and dilion. And that word is basically together means a product that can reveal or manifest information about the mind. And I think more than ever, they obviously didn't know that back in the 50s, but that is what these drugs are doing now. So that's what I'm going to go with. I do like this term as well, disruptive pharmacology. I'm a disruptive pharmacologist right from way back. I'm going to dedicate a lot of what I have to talk about today to this issue of PTSD. I am not an expert in this field. I treat people who suffer from it. It's a terrible disease. I don't need to tell anybody here that. I don't know many experts in this field. I do know a lot of patients. And people in this space deserve a lot more. I don't need to tell you a great deal because you've probably heard a great deal about what it's about. A horrific event resulting in even the way how your mind works. Think about that. Our day-to-day manufacturing of life, family, and whatever, but an event so horrible that the way that your mind works has changed. These are events that none of us can even begin to describe. And we have some ideas. I've used, because it's COVID time, I've used QR codes. You've obviously got, this will not tell you that you're safe. This will tell you where you can get the papers that that I'm quoting. So if you want to use a QR code to get the articles, you're more than free to do so. And so there are lots of interesting ideas from the classical psychiatry literature about how this comes about, and some of them are pretty close to form. So there are risk factors, you need some stressor, you create a chronic stress pathology, and there's a general acknowledgement that something changes about the way that you look at the world that makes the world a difficult place. It's huge, it's vast. There's an extraordinary body of people who suffer from this globally. And the way we live is probably generating more faster than we ever have before. Maybe 350 million patients worldwide, 6.8% of the population in the US. That's 22 million Americans potentially suffering from PTSD. Over 1 million veterans are in receipt of disability payments for PTSD from the Department of Veteran Affairs in the United States. And it costs a fortune. It's not like there isn't a problem in Australia either. You know these numbers. The background rate is maybe 4 to 5%. It's a little lower in people who are actively enlisted in the army, but there's a significant bump in people who have been discharged. You may or may not have noticed the last year has been pretty and that, I think a lot of people talk about PTSD in the context of our veterans, but it's broader than that as well. We've got an opiate epidemic that's ongoing and unabated. The bushfires have created this existential angst within the community, and this is now measurable in terms of responders, first responders, both civilian and military. And last of all, we are only beginning to appreciate the nature of stress that has come from COVID-19. This is something that I think, sadly, those of you who are much more involved in this than I am are going to be dealing with probably for the next decade. All the ingredients are there. There are sort of mitigating factors. You know, we have a good community, say, for example, in Canberra. We support each other. We're probably safer and better off than many of our colleagues, certainly in my homeland. But there are many traumatic stressors. I know for a fact that colleagues in the UK are deeply burnt out and are going to probably entertain a diagnosis of PTSD from what they have endured this year. That's hundreds and hundreds of emergency practitioners. That doesn't take into account what the general community in the UK and the EU has gone through, nor in the United States. And that's happening here as well, to a lesser extent, but it is happening as well. So COVID will have an impact as well. We do try to treat PTSD, obviously. Psychotherapy, as I understand it, is the first line of treatment, followed in a secondary way by pharmacotherapy. Definitely second place. It's not great, is it? Our outcomes, they're not super. We do like the idea that a medicine is going to cure our problems. A lot of people look at psychotherapy in my line of work as a little bit airy-fairy, but in fact, in this space, it probably works way better than medicine in the traditional sense of the word, because pharmacotherapy in this space has been pretty and this is an area now of real and urgent interest. There's a significant increase in case numbers. There's significant drop-offs in pharmaceutical company investments in this space. I'm going to say that the effective treatment is very poor compared to a lot of our more organic medical conditions. And there's a real concern within the medical fraternity about this. So I'm going to give you a bit of this. Is it moving for you? Yeah? It means you've been using drugs in the last 6 hours. No, it doesn't. No, it's just joking. So psychedelic science. It's just so not new. This is ancient stuff. In the 1950s and 60s, it was extensively, admittedly badly investigated. But there's over 1,000 papers in this space with over 40,000 subjects involved. They're largely sort of, here, take this, see what it does. Explorative studies with a whole bunch of psychotherapeutic techniques associated. And so the methodology is terrible. But out of that, there have been at least 4 systematic reviews looking at positive outcome. The sort of eras of actual research in this space are this sort of prehistorical, we're going out for a pint and some LSD, some pre-prohibition exploratory studies, a few clinical trials, and then you saw, particularly in the 1960s and 70s, the 1970s, the International Drug Conventions against psychotropic drugs, it stopped, completely stopped. So we are 30 years behind where we should be in this research. There has been, obviously, problems with the sort of trials that we were mentioning. You know, you wouldn't get ethics approval to do them in the way that they used to be. Prohibition saw this rise of counterculture in the 1960s, and that was, I think, politically considered a greater threat than the drugs themselves. And so the banning of these drugs, well, it was a way of prosecuting the cultures that it was indulging in them. And, you know, we saw this. We saw this with, say, Chinese immigrant gold miners in Australia and their opium, which they used, and cannabis with Mexicans in America. It was a cultural prosecution. There was not a lot of evidence that there was really any harm medically coming from any of these drugs. You saw that in the Harrison Tax Act in the 1920s in America, where the American Medical Association fought the American government with their attempts to ban cannabis because they thought it was such a useful drug. We saw it again in the 1980s with the ban of MDMA. You don't have to be a genius to see what the impact on drug research was. So this is round about the 60s, lots of research happening. The plug was pulled. The nice thing is that we're seeing another resurgence, a resurgence in the research that's occurring. COVID obviously has hammered a lot of this research. It involves interacting with people, face-to-face time, and COVID's not a great agent to promote that. What drugs are we talking about? Well, there's the sort of classic psychedelic drugs, and there are three large categories that you'd think of, maybe. These plant-derived, what they call indolamines, and that's dimethyltryptamine, 5-methoxydimethyltryptamine, psilocybin, which some of you will know from your magic mushroom days, which is metabolized to psilocin. And they're all serotonin agonists. Mescaline is a phenylalkylamine, and there's a few others. And LSD is this semi-synthetic, which comes from ergot. Those are the classics that we largely think of. I'm going the wrong way. Story of my life. And then there are the non-classical drugs, which are technically not actually psychedelics, but are frequently included within this space. Cannabinoids, MDMA. I'm not going to talk a lot about ketamine today because I'm more interested in the illicits, but that's up there as well. So what's exciting about this? Well, these are brand new tools in a toolkit to look at the brain in a way we have never looked at it before, never been able to look at it before. It's telling us not what we think about how the brain works, it's telling us how the brain is working. And it's also this very strange phenomenon where a single agent is resulting in improvement across a wide slew of domains of disease. That shouldn't technically be possible in the way that we have traditionally approached psychotherapy or pharmacotherapy. So this is a brand new paradigm of treatment that we're talking about. And I find it personally quite interesting because I agree with a lot of commentators at the moment is that this field of endeavor might actually present us with some sort of link that we've been looking for ages between psychiatry and neurobiology and neuroscience. Growing up, doing medicine as a kid, doing psychiatry, learning about Freud, it just occurred to me that he was high all the time. He must have been high. I mean, the stuff that he came out with was just bizarre. But actually, it turns out that without any of the tools that we can now use, much of what he was talking about was real. And it can be proven with the neuroscience. And this, to me, is truly fascinating. I'm Irish, and I'm now going to exercise my prerogative to go off on a diversion. So I'm going to divert and talk about the brain, because I can. Our idea of the brain, it's kind of like us, actually. We're pretty simple folk. And we want the simplest possible answer. It's pretty reductionist. And we like to think of the brain, and traditionally have, like building blocks joining together. We don't know how they join together. We assume that they're joining together. We have no idea how they're wired. They're joined to other areas, which we don't know how they interact with each other, and that's what we've accepted as how the brain works. You know, those of you who wander around and say, it's not exactly a brain surgeon, the brain surgeons don't know either. You know, nobody knows how any of this works, or have done over the last decade or so. And historically, nobody's really understood how these things are banging into each other. So you've got this sort of like old-fashioned computer thing, and you know, in our minds, we're like, well, somebody shifted that wire south. And, you know, it's Lego. And much of how we treat issues with the brain not working is sort of derived from that. It's empirical. We've gone sort of, oh, right, well, benzos, eh? They seem to work pretty well for that. I reckon that's the treatment. Go on, let's give them some benzos. And so we've empirically arrived at treatments, not really knowing the how or the why of their mechanisms. But what's exciting now is we're beginning to get some idea about what's actually going on under the bonnet. That's only in the last 10 to 15 years or so. And it's because of two things. The first thing is really cool imaging, how to take amazing pictures without irradiating patients so they glow at night. And massive computers that can put all of this data together and statistically make inferences about what's connected to what. And the results are really quite phenomenal. We are discovering that there are these things called functional networks. And there's this, and if we look at the stats and chuck this into a Cray computer, we can see where these functional networks are connected to and what prompts them to connect to each other. And this is the sort of technique that's used. You see, if your tissue is using a lot of oxygen, the oxygen demand goes up, and the blood carries considerably more oxygen. This is a functional fMRI, functional MRI. So this is a scan that can be done on you while you're awake, while you're thinking, while you're being tested, while your emotional response is being ascertained. And we can look at how much oxygen is going to various parts of the brain and determine its activity. I'm not sure if this will show very well. So there's my very primitive capillary and some slow blood flow, which is probably all you right now. But then all of a sudden, I raise my voice like this, and you go, oh my God, what's that? He's talking very loud, must be important. And the blood flow increases, and more oxygen goes to a part of the brain. And all of a sudden, I don't know do I have a laser? I might have a laser. I do have a laser. You can see bits of the brain light up according to what the stimulus is. There's no dye. You're in a rather unpleasant tube, and a magnet is being fired at you, but that's it. And we can do this all day to you without harming you. You might get bored, but we can do it all day. So there's a slew of data that we can find out. And these are these brain hubs, which are quite distinct to the anatomical networks. They're different. These are functional networks. They're embedded in anatomical networks, but it's the way that the brain is working that doesn't seem to correlate with what simple folk like ourselves might have thought would have been the way it worked. These are crucial for integrating information, for bringing different experiences together and making a meaning of it. What is interesting is that studies in patient populations, not frogs or rats or healthy humans, in patients, show that this bold fMRI can detect altered connectivity in disease states and can distinguish healthy patients from those who are suffering disease. And this has been identified for a slew of psychological and psychiatric conditions. It also is associated with severity of disease as well. So what does this mean in real terms? All the time, we've been kind of looking like a rather inept computer tech at the back of a computer with a jackhammer, saying, I don't know, take that one out and see if it works. And that's what we do when we're giving drugs and taking drugs away and trying a different drug. We're just experimenting to see what works best. But this functional MRI business, this studying of the brain in real time, is like watching a computer that's working. We're troubleshooting a functional computer. In healthy folk who do not have disease, the brain is designed, like everything. Everything is designed to be efficient. There is an evolutionary impost on everything that we have in our body. And if it isn't needed, it'll be bred out of us. So the brain is designed to be efficient. And that the optimal cognitive function of our brain is designed to be that way. But what we also know is that in disease states, that optimal cognitive function goes awry. It changes. And we've seen this using our new imaging. This is often referred to as a hub failure. Some of our functional hubs are not working the way they should be. And there is a supposition, or an idea, that this hub failure is a precursor to some of the most recalcitrant conditions we are being asked to treat. Is it there in PTSD? Absolutely. There's no doubt that hub failure in this way is important in PTSD. There's a summary paper, which I'll show you the QR for, which shows a summary of all the functional imaging. It does appear that new connections, dysfunctional connections, are being made that bypass those things which allow us to participate functionally in life. And they are very damaging to the way that we think about the world. This default mode network, a very well-described network that we have identified now, seems to be quite critical in that space. There's now considerable, by all means, have a look at this. And this is not new stuff. This is just not well described, or not well described in Australia. This is old. There's considerable evidence now for large-scale network dysfunction in PTSD. And it's characterized by a hypoactive default mode network. So what's the DMN got to do with this? This guy here used to be the bane of my life, and I've got greater respect for him than I used to. This default mode network seems to be the location, if you like, of what he used to call the ego. Our sense of self appears to be derived from this place. In PTSD, it seems to work differently. And it turns out that we can measure how that works differently, and we can change it. A hypothesis. So there's a lot of people considerably brainier than me, not only in this room, not only on that table, but like in the world, who are working on this. And it's all very hypothetical still. But Robin Carhart-Harris out of Imperial College is looking at this particularly. He's using PET scans and functional MRI and has a cohort of patients that he's examining. And psychedelic drugs, in the studies that he's done, seem to degrade all of our networks. They seem to detach our ego from itself. Those of you, I'm sure nobody in this room, but those of you who have used a psychedelic drug, those of you who had a religious experience, will know that it involves the appreciation of something greater than the ego, than oneself. And that's important, because that could be useful. There's this sense of entropy. The brain becomes slightly more chaotic. And it doesn't just render the brain more chaotic. It wipes many connections. So what we've got, this is I don't know what they call it, connectogram maybe? A diagrammatic representation of the brain having taken a placebo and having taken psilocybin, the ingredient in magic mushrooms. And what happens when you take psilocybin is a vast quantity of connections that haven't been there occur. Strange, which is why you see strange things. You experience synthesias. Strange things happen because your brain doesn't normally work that way. And then it subsides and it goes dark. And in that darkness, functional networks recur. That which was there rebuilds because something has to fill that space. And this is what's happening with these psychedelic medicines. The brains, the networks which have been damaged, reconnect in healthy ways. This is hypothesis, but it is supported by clinical findings. So you get this functional rewiring that occurs particularly if it's done in a therapeutic environment. This is largely what's happening. Now, it's really complicated. It's like super complicated. This is like 1 trillion neurons rebooting together. We do have no way of modeling it in its entirety, but we can do with disease states. I'm going to switch back again to some specific drugs. Start with the cannabinoids. So we're going to talk about how they might work, how they could be used, what's the evidence for them working, and can they hurt you? Cannabinoids, come on, it's Canberra. You're all smoking at nighttime. I know, I don't, but you do. It's incredibly common, and it has been used medicinally up until the 20th century, widely. Obviously, it had been banned, and as a consequence, we didn't even know what was the endocannabinoid system until about the 80s and 90s. That's how impaired our understanding of this product has been. But it's seen to be a reasonably promising target for the treatment of several diseases, including PTSD. How might it work? Well, it acts on the endocannabinoid system, obviously, and it has a role on emotional memories. We know that chronic stress causes a downregulation of the CBR1 receptor, and that's associated with symptoms such as hyperarousal and sleeping problems. And intrusive memories seem to be facilitated by decreased endocannabinoid signaling. So there's some good pharmaceutical basis there. So there has been, therefore, obviously, some speculation, not just on the pharmaceutical basis, but on the number of veterans who get relief from smoking a bit of weed. It's probably different to some of the other compounds we're going to talk about, because it's probably most useful in temporary relief for people who are having a flare. We don't know much about what its use in a psychotherapeutic environment might be, because it's not really been looked at very well. But it certainly does appear to be used very frequently within our veteran community. And I think I'll just move on to, oh, I'm doing it again, aren't I? Jesus, now I've got it upside down. A lot of the time, unlike many of the other agents that are on offer, and certainly in the United States, this is being prescribed as a take-home medicine for people to use off their own bat. It's not really been studied very well within a psychotherapeutic environment. You can take it a whole bunch of different ways, and the duration of its action is dependent upon how it's consumed. There's been a few studies looking at it in PTSD. Reutemann et al. Looked at 10 outpatient patients who were taking other drugs as well, and there was significant improvement in that group. There has been a placebo-controlled trial with a synthetic cannabinoid called nabilone, and that demonstrated very small quantities of people, but that demonstrated some benefit. But there are now currently over 50 trials underway in this specific space. And that's obviously a function of the increased availability of cannabinoid medicine globally, not in Australia, obviously. Can it hurt? Yeah, well, it can be bad for dentition. It can dry your mouth out. It can cause dizziness and fatigue. It definitely can cause nausea and vomiting. Some people can experience anxiety. Will it put you in the bowels of hell with Moloch and morally crucify you? No, it won't. It is not a moral drug. It's no more moral than paracetamol. It has a different function. And this is part of the problem, is the morality of this drug use impedes our ability to assess them. There is some debate as to whether or not this might lead to a cannabis use disorder, and then a lot of veterans counter that by saying, I don't have a cannabis use disorder. I am using this drug because of PTSD. So maybe it's actually driving people with PTSD to using cannabis for relief. There's not really a major safety issue with the cannabinoids. I think this is where a lot of interest lies now, globally, with MDMA, or as you would know it, ecstasy. It was first synthesized in 1912 by Merck Sharp and Dohme, and interestingly used as a chemical warfare agent in the 1950s in the United States, presumably used to make people love each other and not want to go to war or whatever. In the 1970s, it was rediscovered, and there was actually a very active treatment, underground treatment program in the United States from the 1970s all the way through to 1985 of people using this for the treatment of PTSD, manufactured and distributed by Alexander Shulgin, handed off to Leo Zoff, and then distributed around America. In the 1980s, therefore, we saw this leakage, this filterage from the therapeutic environment into the recreational scene. And there are some people who would argue that, in fact, because of the anxiogenic nature of the modern world, it was a lot of people actually self-medicating. Very controversially, it was scheduled in 1985 in the United States. In fact, the DEA received numerous letters arguing, because of course, it has been claimed that it is a product that has no therapeutic benefit whatsoever. And it was being used therapeutically. But that logic has never been a problem for our political colleagues. And so it actually took a presidential edict to ban, because the DEA decision was overthrown by the medical profession. So there's been a hiatus in clinical trials since 2000. It's been investigated for PTSD, for alcohol use disorder, and for social anxiety. And so successful has its use been overseas that the FDA has designated MDMA-assisted psychotherapy as breakthrough therapy. It's accelerated. All bars are off to approve this drug for the treatment of PTSD. How might it work? Well, it's fascinating. Like I said before, this is a novel paradigm. We're not really familiar with this approach. It acts as a catalyst to psychotherapy. My understanding, and my hat's off to people who treat patients who have PTSD, it's very traumatic. And frequently people cannot go back and address the issues that gave them this position. And MDMA allows you to do that. Allows the therapist and the patient to revisit this traumatic event together. It increases personal trust with the person who's treating them. And contrary to popular belief, it does not space you out, make you dance really hard to bad European music. There's almost no cognitive change whatsoever. It's quite a unique drug. It's empathogenic. It makes you empathic to other people. And so patients, very importantly, retain a clear memory of the experience. How would it be used? Well, I can tell you how it is used. It's embedded in a psychotherapeutic environment. You have several sessions beforehand talking about what it is you're going to do. Then there are maybe 2 or 3 sessions under the influence of MDMA. It happens in a nice place. It's clinical in case anything bad happens. And the sessions last about 5 to 8 hours. They're usually accompanied by 2 therapists. And the MDMA is administered orally. 75 milligrams, that would be about enough to get most of you where you need to be. With the exception of myself and that sturdy-looking gentleman there, I think we probably need a slightly bigger dose. Yeah. So, but most of you get where you want to be, about 75. And then there's the opportunity to have a supplementary dose during the course of the therapy. And typically, this happens 2 or 3 times. The important thing here is that this is just an adjunct. It's not like your SSRIs or whatever. This just facilitates the psychotherapeutic intervention. And then it's done. You're done. You're not taking MDMA for the rest of your life. You have 2 or 3 doses. So does it work? Well, the first trial, I mean, obviously these trials are impossibly difficult to get underway because of the legal status. The first trial was done in Spain in PTSD associated with sexual assault. And it was only small, 6 women who all had great benefit, but it was too small to judge statistically. But it did show quite clearly that it could be safely used within this group. The first randomized controlled trial was published in 2010. There's 12 patients. But this is bonkers for this particular condition, that 83% of the patients in the MDMA group no longer met criteria for PTSD, compared to 25 in the placebo group. That's bonkers. That should not happen. That's not the experience of any drug treatment of PTSD anywhere. And the thing that's even crazier is the fact that this was stable at 3 years. Yeah, in my career, I don't come across these sort of numbers that often. That's just out of this world. These findings have been replicated in 2 other studies. A pooled analysis has confirmed all this. At 2 MDMA sessions, 50% of patients no longer met PTSD criteria. This is considerably cheaper than current pharmaceutical treatment of sertraline and paroxetine, which does not endear it to the pharmaceutical industry, I can tell you that right now. And as a consequence of these sort of findings, the FDA granted breakthrough therapy designation. It can cause bruxism. I see the overdose effects all the time. So that's gurning and jaw tightening. Headache, fatigue, anxiety, perhaps, if you're not anticipating what's going on, can have a sympathomimetic effect, maybe a bit of hyperthermia. There are some, I would say, conservative authors who are very worried about the potential for your brain being fried on therapeutic MDMA, but that doesn't appear to be the case whatsoever. It almost never appears to be the case in anybody who uses MDMA recreationally or medicinally. But in a therapeutically monitored environment, there's been never anything of any seriousness ever documented. Some very interesting models about how this is being rolled out globally. The Multidisciplinary Association of Psychedelic Studies is a non-profit and established in 1986. Rick Doblin is the guy behind it. And they've, because of the difficulties in this field, have privately been fundraising and have raised a lot of money to get these trials underway. Phase 3 trials are expected to include up to 230 patients, and they probably be completed at the end of next year. There has been obviously some delays because of COVID, and maybe even full approval is what MAPS are looking at by 2022. If approved, importantly, this is not going to be like an antihistamine. You're only going to be able to get it from referral by a doctor and be administered it within a supervised setting. There are ongoing phase 3 trials in 15 sites in the US, Canada, and Israel. And, well, Israel, obviously, because of where it is and what it goes through, has announced a compassionate therapy, allowing 50 patients to receive treatment. MAPS is rolling it out to an expanded program at the moment. Patients do have to pay for their own therapy, but it's actually a surprisingly cheap drug, and that's what they're covering, the cost of the drug. It's also rolling out trials in Europe as well, but they've yet to begin recruiting patients. One of the areas of research is what dose should we give, and it's probably about 0.5 milligram per kilo of body weight that works, with maybe a top-up. We'll talk a little bit more about that shortly. I'm going to just touch on the classic psychedelics that those of you who are old enough were using in the 70s and 60s. They're judged by many psychiatrists back in the 50s and 60s as really useful tools. But then, again, we had this culture war and they were banned. But since the 2000s, these are actually emerging again. Sorry, this is too busy a slide. There's quite a few different types of studies going on. Proper pharmacokinetics, mechanisms of actions, brain imaging, phase 2 trials. Psilocybin, importantly, to take home from this, has been also designated breakthrough therapy by the FDA. The FDA, for those of you who are unaware, is the Americans' TGA. So that, you know, notoriously conservative. So psilocybin is definitely on the fast track as a therapeutic agent. How might they work? Well, we talked a little bit about that, about the business of creating a great many connections and overriding those ones which are dysfunctional. Reestablishing in an environment where there is no further threat what the normal connection should be. That's far too busy. How would they be used? Probably in the same setting as the MDMA is used. So that's what's being used in Imperial College in London. Is the bonus if you're getting psilocybin or LSD therapy is you get to listen to some music as well. Clearly in the company. It is often, so it's not guided in the same way as MDMA is, but in the company of people who are there to make sure that you're okay. Does it work? It's actually hard to say for PTSD, and I'll be quite honest about that. The experience that we have of it probably is too early to say. It was used quite extensively in the Netherlands in an era that predates the formal diagnosis of PTSD. At one time, my understanding, and somebody can correct me, is that PTSD was only designated as an official disease in 1980 in DSM-3. And that prior to that, there was terms like shell shock or concentration camp syndrome and whatnot. And this Dutch guy, who is something of a legend, Jan Bastians, treated hundreds of patients to good effect, documented his findings in 12, which was a bit useless, but had great effect in that space. There is interest in another product, which you've probably heard of, called Ayahuasca, which is a traditional psychoactive used for centuries by indigenous people in the Amazon, not for recreational purposes, but for medicinal and spiritual purposes. And it's rather clever. It's got a dimethyltryptamine-containing plant. Our body is normally protected from dimethyltryptamine by monoamine oxidases in our gut. And so if we eat this stuff, it'll, well, bluntly, we'll just through. But there's another plant which they put in this concoction which inactivates the monoamine oxidase, and so the dimethyltryptamine is absorbed and you trip. And you have a full-blown psychedelic experience. So Bia Labate is looking in South America at the moment at running trials of ayahuasca, formal trials in veterans there. Can it hurt? Yeah, sure. If you're doing this, and this is one of the things that drives me mental, it's terrible. We know for a fact there's like hundreds, probably thousands of people in Australia who are using illicit drugs for the purposes of trying to get relief. And these drugs of this sort of potency are dangerous potentially if you're not using them in the right way, if you don't know what you're using. They require medical supervision for them to work well, I think. So yeah, they can hurt. They're generally speaking not toxic. So this group of psychedelics rarely poisons you. But what it will do is change your behavior if you have a bad experience in such a way that you might well indulge in activities that will hurt you. I wish that we were looking at this purely from a philanthropic basis, that we could be convinced by the evidence that is emerging that this is going to be terribly useful for people who have sacrificed a great deal for us. But the reality, as with cannabis in Australia, is that that which is driving this globally, is the bottom line. It's the money. The savings that could be made from what we're currently doing for this group of patients compared to what could happen if we moved our practice run to billions of dollars. At least several war memorials. It's not just these drugs and these conditions. There's the success of these drugs has now expanded interest in a wide variety of other substances. This is a fraction of what is on the cards for the future. And yet, we still are limited tremendously by the scheduling. It's very, very hard to do this sort of research, to acquire the materials needed to get pharmaceutical-grade MDMA. That is really difficult. One of the biggest problems in the United States has been that the official supplier of cannabis product, El Soli, has nowhere near as good as product as can be provided by the illicit market. And so that which can be purchased as a pharmaceutical, up until very recently, didn't have the same effect as what people could get on the black market. And this sort of product access is terribly problematic. What about Australia? Well, there's been attempts to advance the case here. In 2012 to 2014, we got involved in a whole bunch of negotiations. And again, the position was, behind closed doors, do you know what? Completely agree with you, mate. This would be, we got to do this. The politics isn't right. So there is acknowledgement that this needs to be done. Anybody who can read a science journal knows that this needs to be done. But it is not science that is stopping progression in this space. Personally, I had multiple meetings with some lovely folk from the DVA, the RSL. You're all good eggs, whoever you are. And I know what it's like. Well, not really, but I appreciate what it's like to have your hands tied. I'm completely, as you see, disinhibited. I have no frontal lobe, so I'll say what I like. But you can't. You can't. I appreciate that you can't. There are significant issues with stigma and politics. I'm sorry, I'd be a little naughty here. So this is something that happened with cannabis as well. So about a month before the National Academy of Sciences in the United States released their report showing that there was compelling evidence for the use of cannabinoid medication as an analgesic in chronic pain, the Australian guidelines were reduced saying that there's no evidence at all and we shouldn't even be thinking about it. And curiously, I didn't know this, but this happened also with hallucinogens for PTSD. This is the same year this was released. I apologize to any authors, and I'm sure that this is something to do with the delay in getting information from the world to Australia. It's a long way, I know. But the same year that this was released, the accelerated approval was granted in the United States. So there's two different ways of assessing this literature that's out there. So in Australia, we decided cannabis, no evidence. Hallucinogens, I think is the wrong name, but no evidence. And the FDA they're like the pharmaceutical equivalent of nuns, said, oh yeah, go ahead, go on, make loads of it. So there's a problem here, and I don't think it's to do with your capacity to interpret the science. So the important thing is that both MDMA and psilocybin have been given accelerated approval, and that means they're going to come online far faster than if they were any other drug. Has stigma gotten away? Yeah, definitely has. So Wellcome Trust is the largest charity in the UK. It's worth billions. Its focus is neuroscience and brain science. It's a pharmaceutical company funded. And it was approached by the Imperial College research team in the 2000s, and even they said, no, it's politically too risky. In the United States, the VA, the Veterans Affairs, won't sponsor this. That's why they had to set up their own funding model, because it was too risky for, ideology. There are Australian trials. I thank Stephen Bright for this. This is a list of what's going on at the moment. The Psychedelic Research in Science and Medicine group is currently recruiting for a small study looking at psilocybin-assisted psychotherapy. There's studies which have got TGA and ethics approval. There's proposed studies. But with great respect to my colleagues who are trying to do this work in Australia, it is small potatoes compared to what's going on elsewhere. There's a few others that are not affiliated with PRISM. The College of Psychiatrists has got a pretty good position statement on it. They're the guys who approved pill testing. So they're pretty up with the facts and the research. And they've come out and said, we probably shouldn't be doing this research unless it's got ethical approval. Well, it's very straightforward. But they aren't saying that there's no evidence. They're saying that there's emerging evidence. And they're right. This was in 2020. And so there's a lot of things now that are making the case for a push forward in this field. There's growing evidence of safety and efficacy. There's really limited abuse potential. If people are telling you that they don't understand illicit drugs, these are novel actions. This is very exciting for people who like treating things. Not only does it work quickly, it lasts. And there's going to be some money. What do patients think? It's very hard to find any that aren't overthrown by it. This is something that changes their life. And perhaps that's something that really we should be considering far more about, rather than the political palatability. Because in the end, this is really what we're here having a chat about, is what can we do to make the life of these patients better? These patients want this. That's what's important. There's an awful lot of jockeying for money here. I think we've seen that in the cannabis sector as well. A lot of people see a lot of money in this, and that's not good. I don't like that. Because when that becomes involved, then things sway. So there's a lot of prospectuses being issued out there, and we have to be careful that this doesn't get taken over and become an additional tobacco industry or alcohol industry. This is par for the course. They're looking at share prices and the way things are going gangbusters for companies looking into the development. And it shouldn't be that way. But this is happening because governments aren't getting involved. This should be controlled. But it's going gangbusters because the commercial entities are seeing what is required, what is needed, and the opportunity. There are some seriously heavy hitters on board. So Johns Hopkins has been running psychedelic studies now for probably the best part of 20 years. Imperial College, one of the biggest, most prestigious universities in the world, has just opened its Center for Psychedelic Research. And I think you'll see many more Ivy League and major hitters opening centers for this globally. We're quite some way off that in Australia. It's going to be a hard wall to get over this. We have to accept that these are products that have definite pharmacological activity, and there's a significant signal there. You're a liar if you're saying it's not. There's also, and we found this more recently, the Global Drug Survey has shown quite clearly that there are thousands of people using precisely these sort of drugs for therapeutic purpose, not to get high, but to make themselves feel better. Clinical trials in this space, how do you blind a clinical trial where you're having a conversation with a chair? It's very hard to give a placebo that mimics that. These are psychedelics. These are potent drugs. So there are attempts, say, for example, giving intravenous niacin, which gives you a sort of a buzzy, warm feeling. That's some people who are naive to the effects. But once somebody has had this drug, they know what that feels like, and you can't do any other blinding. There's this issue of a moral hazard, which I frankly reject. I completely accept somebody's right. And I do, regularly in emergency medicine, somebody doesn't want to have a blood transfusion for ideological purposes, that's cool. Don't have a blood transfusion. Do you know what? You're not going to get a job in charge of the blood bank, though. I respect your personal decision, but your personal decision shall not be inflicted upon the rest of the polity because of what your own beliefs must be. This is also threatening to pharma as well. I think we saw that with cannabis too. The safety, which is kind of my gig, is really not as serious as it's made out to be. In medical supervised conditions, this is really safe as houses. I'll finish up now because you'll be bored. But I see strong similarities in this space to the climate change debate. The dominant narrative is largely flawed. It's historically old. The alternative narrative is very naturally gaining momentum. It is going to outbreed the dominant narrative. That's the way it's going to work. It's driven by special interests on both sides. So there are nasty people pushing psychedelic medicine, and there are nasty people who are opposed to it. Those who have the most to gain are given the smallest platform. The patients are left with almost nothing to say, and those that can make a change are disinclined to do so. And this is Australia, always late. I just think, my mum tells me that she can't get in touch with me, and I just tell her that it takes a long time for the telephone waves to get here. And it's the same with information as well. There's knowledge transfer. The days in which you were leading, certainly in drugs policy, probably date back to the AIDS campaigns. That's it. That's the last time you were global leaders in drugs policy. And you're late again here. The problem that you have, say, with cannabis, is that you were late to the therapeutic cannabis debate, and the rest of the world now has a glut of it. You can't offload all the cannabis you're trying to grow in Australia. It's sitting there. You've got bales of the stuff, and nobody will buy it because everybody else is buying it from someone else. And these are the consequences of not thinking this through well. So we live in interesting times. It's a curse. It's a curse to live in interesting times. Psychedelics are clearly telling us something about the brain and the mind. And medicine has great promise. We are, as I've said, about 3 decades behind where we should be. Australia's maybe 4. Australia is clearly not an early adapter in this space. And the rest of the world isn't holding on going, oh God, what's Australia doing? Let's wait for them. That's not happening. You don't see that in climate change either. Nobody's hanging on to your every word. I'm sorry. The need in Australia is substantial, and the risks could be significant. And the benefits could be significant. The risks have been overstated. I think the most important thing to do in this space, when you're providing therapy to a group of people who, God damn it, deserve it probably more than they put a goddamn badge on their arm and fought for you, is that you show some moral courage, the same way that they did, and some kindness. This is from my kids. This is from, I think, Cinderella. But there's great wisdom in this. If we are going to change this in this country, in so many other fields of academic endeavor, the only way we're going to do it is to have courage and to be kind. That's been me. If you want to see what I look like without a beard, that's me. This is not because I'm afraid of your temperature or anything like that. This represents 230 days of no COVID transmission in my jurisdiction. And the sooner we get COVID back again, the better, I say. Because I'm roasting here. I'd be delighted to chat with you. I spend my time debating these things. I know that I've said things that you're going to disagree with profoundly. I know that I'll change your mind eventually, because I'm more persistent than you are. But I will meet with every single one of you and talk to you about this at any time that you want to, because I think it's important and we owe it to people. Thank you for your time. Oh, before I forget, I'm not in any way affiliated to this chap, but if you want to read a lot about this in a short period of time. This is a book that's changing a bit of things. This is Michael Pollan's book, How to Change Your Mind. It's very well referenced. He does some TEDx talks as well. If you want to learn a lot more than what I've been able to cover in the short period of time allocated, I would commend this to you. It's very easy reading, and it will point you in some directions that you might rather you hadn't gone down. Thank you again.